Welcome to RAAONLINE, and today's topic will be on Lipomyelomeningocele, which is one of the forms of spinal dysraphism. So, to briefly go into embryology of the spinal cord involves two processes. One is primary and the other is secondary neurulation. Primary neurulation occurs between the posterior days between 25 and 48. Basically, the primary neurulation is the one which forms the actual neural tube and is involved in the closure of the anterior and posterior neuropore. So, primary neurulation happens between 18 to 27 days, whereas secondary neurulation happens between 25 to 58 days. So, both these processes take place between 25 to 48 to 58 days in total. So, closure of the posterior neuropore marks the end of the primary neurulation. So, after this what happens is the secondary neurulation, and at this point the fetal spine is covered by ectoderm fully and only the lumbosacral and coccygeal segments have not been developed. So, at the end of primary neurulation we have a fully formed spinal cord except for the sacral, coccygeal and the terminal segments. So, any defect for LMMC to happens during the secondary neurulation phase. Any defect in primary neurulation, that is when the anterior neuropore or the posterior neuropore has not closed, leads to much grosser deficits, which are usually encephalocele or a myelomeningocele, where the skin itself is deficient. So, what is secondary neurulation? So, as we saw, only the caudal end of the spinal cord is yet to develop once the primary neurulation is over. So, the caudal end, which usually has undifferentiated cells, these condense to form what is called a caudal cell mass. So, this is the starting of secondary neurulation, which happens around 28th day post ovulation. This is the first step, formation of a caudal cell mass. Once the caudal cell mass has formed, the second stage or the second step of secondary neurulation happens, which is called canalization, where the caudal cell mass cannulates and there is a terminal ventricle which forms here. So, this caudal cell mass is here and there is canalization happening, and this usually happens between 27 to 29 days post ovulation. So, as we can understand, these undifferentiated cells are totipotent and they have to de-differentiate or they have to retrogressively differentiate into only three structures at the end of it, which is the phylum terminal, coccygeal ligament and terminal ventricle of the conus. Only these three structures remain at the end of retrogressive differentiation, and basically the embryological tail and all other undifferentiated cells vanish, and this usually happens between post ovulatory days 48 to 52. So, these are the three steps. One is formation of caudal cell mass, second is canalization of the caudal cell mass, and third one retrogressive differentiation. So, what exactly happens in retrogressive differentiation and whether there is early disjunction of the spinal cord from the skin is where defects lie in LMMC. So, as I mentioned in my previous slide, caudal cell mass has totipotent characteristics, and the bony vertebrae which subsequently develop around the spinal cord, the sacrococcygeal segments especially, they also should undergo regressive changes to decrease the number of segments which are originally present. So, all this differentiation is also affected, secondary neurulation is affected. As a result, we find vertebral malformations also a part of neural defects when we neural defects during this secondary neurulation phase. So, McClone and colleagues came up with an embryological basis of lipomyelomeningocele, and they suggested that premature disjunction of the closed neural tube, that is the neural tube after primary neurulation, and this premature disjunction from the cutaneous ectoderm is where the primary problem exists. So, since there is a premature disjunction, a dorsal cleft exists, and this dorsal cleft permits paraxial mesenchyma to have access to the lumen of the neural tube, and this paraxial mesenchyma which enters into the lumen of the neural tube prevents its complete closure and leads to the development of a lipomyelomeningocele. So, the luminal surface of the ectoderm which is within the spinal cord induces these mesenchymal cells which had entered from the paraxial mesenchyma, and they differentiate into a adipocyte formation path, and because of this we have the development of lipomatous cells which are usually present from the subcutaneous tissue along the tract and also in the spinal cord. So, basically the intraluminal adipocytes here form, and along the tract also they will be having adipocytes and also in the subcutaneous tissue. And according to McClone, this all arose because of premature disjunction and a persistent luminal axis through which the paraxial mesenchyma have gained access into the lumen. So, there are several other tissues which have been found, which is striated muscle, cartilage, nerve cells, ependyma, and even cerebellar tissue have been found. Not only lipomatous tissue, that is adipose tissue, you can find a variety of these cells. So, maybe apart from the mesenchymal origin of these cells, there is a possibility that the caudal cell mass which had a totipotent characteristic could have given rise to these structures. Several authors have also found that patients with lipomyelomeningoceles have other problems like split cord malformations, terminal synomelia, syrinx basically, and there can be neuroenteric or intraspinal dermoids which can be present in up to 40% of patients, especially with the dermal sinus tract. So, there can be a tight phylum terminal or there can be a fatty phylum terminal, and there can be other tethering tracts also apart from this tight phylum terminal. So, how do you approach a child with a swelling in the back? So, there is a child with a swelling in the back, and this swelling can be skin covered or not skin covered. So, if there is a skin covering, we have the understanding that this is happening after the primary neurulation, skin covering is present. So, this is usually an LMMC. If skin covering is not there, we know that this could have happened during the primary neurulation phase, and it is probably due to the inappropriate closure of the posterior neuropore or non-closure of the posterior neuropore, and this can be defined to be an MMC or a myelomeningocele. So, this is one way of assessing patients with a swelling in the back, and then you go on and ask yourself the question, is there any neurologic deficit in the child? If there is a neurologic deficit, it is usually a myelomeningocele or a lipomyelomeningocele based on the presence of a skin defect, or it could be a split cord malformation also, or it could be a terminal myelocystocele. If there are no neurological deficits, both sensory and motor, it could be a simple meningocele without involvement of the nervous structures, or still it could be an asymptomatic lipomyelomeningocele or a split cord malformation, or it could be a limited dorsal myeloschisis. So, this way we can differentiate patients who are having deficits and not having deficits, and those who are especially in children with having a swelling in the back. So, Chapman and Pang's classifications have classified LMMC into mainly 3 primary types. So, these are the 2 most commonly used classification systems for lipomyelomeningocele. Chapman's classification is into dorsal, transitional and caudal. So, if you can see, there is a series of pictures given here to help us understand these 2 classification systems. So, here in the first picture we see a dorsal type where the tract is dorsal and it is behind the caudal end of the spinal cord, and we say that the dorsal root entry zones of the nerve roots will be ventral to the lipomatous tract. The lipoma cord interface is posterior to the dorsal root entry zones of the roots, and generally they run on the anterior edge of the lipoma, making dissection a little easier for the neurosurgeon. So, what is a transitional type? Transitional type is one which goes not only behind the cord but also inferior to it. So, this can be seen in the caudal type also, where the dysraphic portion is completely below the cord, and usually we see the nervous structures all going through the lipomatous tissue or in front of it. So, this makes dissection around the lipoma a little difficult in the caudal variety. So, we can actually understand transitional type as one which is dorsal plus caudal varieties. So, Pang basically subclassified transitional varieties into transitional and chaotic, where in transitional we have the roots going ventrally still, and in the chaotic variety the roots run into the lipomatous tissue. So, as we can see in these diagrams that I have taken from human, so dorsal type is one where the lipoma cord interface is behind the dorsal root entry zones. So, we will not see roots coming into the lipomatous tissue, and the lipoma cord interface is completely behind the dorsal root entry zones, and the spinal cord caudal to the interface is usually normal. So, what is the caudal or the terminal type? Here the lipoma cord interface is more diffuse as compared to the dorsal type, and it is usually vertically oriented. There is no lipoma, as you can see, rostral to it, and we see that the nerve roots may be either ventral or most likely could pass through the lipomatous tissue itself, making dissection difficult, and usually they are asymmetric, involving more on one side of the cord or one side of the nerve roots. They involve more commonly, and the patient symptoms also may be onto one side. The transitional one is a combination of both the caudal and the rostral variety, where the lipoma cord interface extends from the rostral end of the myeloscasis. So, if the myeloscasis is here, and they usually extend above the rostral end of the myeloscasis and go up to the conus, which is here, and the lipoma cord interface is dorsal here, but we also see that the dorsal roots enter, the cauda equina can enter at or above the interface, and they may be a part of the lipomatous tissue. So, Pang introduced a chaotic type. So, lipomyelomeningoceles are the dorsal in an orderly fashion, but it's in the caudal portion. If we see, they are ventral to the neural placode, engulfing neural tissue and nerve roots. So, basically we understand that the rostral portion is more orderly and the caudal portion has a lot of neural tissue entering it, and this is Pang's chaotic type. And the fusion line, which is usually distinct rostrally, is as we go distally becomes more blurred and diffuse, making location of the dorsal root entry zone and the nerve roots very unpredictable, and surgical resection in these cases are usually very difficult. It is an uncommon variety and usually associated with sacral agenesis. So, with regard to epidemiology, I would like to mention mainly this point, which patients usually keep asking, of how to prevent these from recurring in the next child. So, periconceptional folate therapy has found to reduce the incidence of lipomyelomeningocele. We are not talking about MMCs or encephaloceles alone, but periconceptional folate therapy has known to reduce the incidence rates of LMMC. By periconceptional, I mean at least 1 month prior to planning the pregnancy, the patient starts taking therapeutic doses of up to 4 to 5 mg of folic acid, and this continues into the first trimester up to 3 months. The patient receives folate therapy, and possibly the rates of lipomyelomeningocele in the next gestation will be lesser. So, what are the clinical features of these patients? More than 90% tend to have a cutaneous stigmata, which is usually a lipoma. So, this lipoma is classically described as a non-tender, full thickness skin covered swelling in or near the midline. Some swellings may be to one side, but they are never too far away from the midline. So, other cutaneous stigmata are hypertrichosis, hemangiomas, dermal sinus with a dermal sinus tract probably going in, and then there could be skin dimples, skin tags, atretic meningoceles, or a caudal appendage. A limb appendage also can be there like that arising from the back. So, what are the other associations? Usually other genitourinary tract abnormalities can be present: cloacal extrophy, bifid uterus, duplicated vagina, anterior sacral meningoceles, abnormalities of the lower limbs, which is usually CTEV, congenital taripus equinovarus deformities in these children are very common, and imperforate anus are also commonly found. Very rarely there can be development delay, where the child will have delay in attaining its motor milestones or a social milestone. There can be associated hydrocephalus or KRE1 malformation with these patients, and very rarely they can have other brain anomalies also present. So this is more common, and especially the orthopedic deformities of the lower limbs are also very commonly associated, making multidisciplinary care of these patients very important. A pediatric ortho team and a pediatric surgery team along with a pediatric neurosurgeon are very essential, making a trifecta of managing these patients with lipomyelomeningoceles. So what happens to these midline dermal sinuses found below the natal cleft? So any sacral dimple is considered a significant finding when considering it as a cutaneous stigmata for an underlying neural tube defect. But when this dimple or the dermal sinus which is noticed on the skin is below the natal cleft, it is highly unlikely to be associated with a lipomyelomeningocele. These are termed coccygeal pits, and Bradley et al. In a review of literature suggested that the risk of developing an associated neurological infection or a deficit is exceedingly rare in these sinuses below the natal cleft. So only 7 individuals in English literature have been reported to have an intraspinal abnormality in patients with coccygeal pits. So a pit or a sinus below the natal cleft is highly unlikely to be a marker of an underlying neural tube defect. So let us understand the definition of tethered cord syndrome. Tethered cord syndrome is primarily a clinical phenomenon. So it can never be a radiological diagnosis. So by meaning it's a clinical phenomenon, it usually involves the patient complaining of a worsening deficit, and usually this results from anatomical restriction of the normal movement of the spinal cord above. So it basically prevents the ascent of the spinal cord, or this could be due to a vascular compromise due to hypoxia in the distal structures of the spinal cord. So this tethering can be acquired, can be primary congenital. So by tethering, we mean that the patient develops new onset symptoms which usually involve worsening of bowel bladder or motor deficits in the lower limbs, and this is usually due to the prevention of the ascent of the cord normally which occurs, or there is worsening hypoxia in the distal portion of the spinal cord, and these two phenomena only explain the clinical deficits of the patient. And merely seeing a lipomyelomeningocele on the radiography, that is an MRI, doesn't mean that the child has a tethered cord syndrome. Why we are so specific? Because these clinical features of the patients are so varied. They may have deficits at the time of birth, and this may be due to an abnormal development of the spinal cord and the nerve roots itself. So when we identify these patients, we usually tell them that the chance of surgery helping their already developed present deficits may not be addressed with a surgery. So these deficits which are present at birth are usually non-correctable. So we need evidence of tethering of the cord, that is worsening of these symptoms can be worsening of neurological, orthopedic or urological issues. These patients are usually candidates for surgery, or we explain a prophylactic surgery in these patients, not to reverse these deficits but to prevent any future deficits. So what happens to patients with asymptomatic lipomyelomeningoceles? Usually they may develop insidious onset deficits, and many times these deficits happen over years, and very subtle changes which are difficult to pick up in childhood except for the mother. So the mother is the one who usually identifies these children with new deficits, and she is the one who gets the antenna up and informs of subtle changes, subtle deficits in these children, and rarely they are acute. In the case of asymptomatic women who have been when they were placed in lithotomy position in their adulthood, or in patients who had hypoflexion injury in motor vehicle accidents, these are some rare case reports where there have been acute deficits in asymptomatic patients. So other clinical features are back pain without any radicular nature. This back pain is usually funicular dull aching and more in the nights. These patients can have muscle weakness and significant gait disturbance, and they usually have a mixture of LMN and UMN signs. LMN and UMN signs will be present. Usually they may have a exaggerated knee jerk with an absent ankle jerk, and they usually have deficits in their feet. They can have muscular atrophy, limb length discrepancy due to the orthopedic deformities. They can have varus or valgus foot deformity in one or both legs. They can have hammer or claw toes. Scoliosis is also a very common condition present in these children. They will have, as I mentioned, mixed deep tendon reflexes, which may be absent, normal or increased, and they also have mixed or patchy sensory abnormalities. The voiding pattern in these children may be abnormal. They may have urinary or fecal incontinence, and sometimes because it's children, it's very difficult to assess whether they are having a urinary problem or not. Dribbling of urine in infancy, that is 1 to 2 up to 2 years of age also, not only in infancy, is a very significant symptom of an abnormal urinary system. And then when the frequency of urination also increases, we suspect that there is worsening of urological deficits. Sometimes the child may present with urinary tract infections, which are usually recurrent, and this may be the only presenting symptom. So, as I mentioned in my previous slide, to conclude, infants usually present with cutaneous anomalies like a swelling in the back or a nevus or a tuft of hair, whereas the older children, which is usually up to teens, you can see them coming with orthopedic deformities, neurological or urological symptoms. And usually the adults, they usually don't have these symptoms, but they often present with pain. So, what are the surgical indications in these patients? We usually offer surgery as a prophylactic measure in these patients given the natural history. Keating, Hoffman have both documented problems in patients. Up to 80% of these patients, 80 to 90% of these patients develop urinary disturbances or deficits when left untreated, and they usually develop this by 5 years of age. And it is known that 2/3 of children by the age of 4 years have abnormal neurological and bladder function at 4 years of age. So, given this natural history, it is pertinent that these patients are offered prophylactic surgery. They have to be informed probably at birth to make a planned decision as to when we can operate these patients. Usually surgery is offered somewhere anywhere between 6 to 9 months of age, so that we can accommodate for the blood loss, and the fineness of surgery also reduces once the age of the child increases from birth. So, anywhere between 6 months to 9 months is an ideal time to operate these children prophylactically, and there should be preservation of function at least at L3 level, so that we are able to make them stand and ambulate them and make them independent for their activities of daily living. If L3 level is already affected at the time of birth and they have, or at the time of presentation to us, it is highly unlikely this surgery is going to be helpful, especially if there is bowel and bladder involvement already. So, the goals of surgery are primarily to prevent the progression of these fixed deficits or the development of new ones, rather than to reverse the deficits which are already present in these patients. So, the preoperative workup in a newborn child in the neonatal period or infancy will include an ultrasound just to confirm, and it will be a more of a screening tool. So, plain radiographs can identify vertebral body defects, especially in the posterior column of the vertebrae. We can identify these vertebral body defects, which are usually absent lamina or butterfly vertebra, which are identified. And X-rays also help us to identify whether the child is already having scoliosis, and we can have it as a baseline to compare serial imaging later during follow-up. An MRI lumbosacral spine with thin T1 weighted axial cuts up to coccyx is the investigation of choice in these children. So, we can plan this sometime when the child is about to be planned for surgery, maybe at around 9 months to 12 months of age. We can get this done under general anesthesia, and this MRI lumbosacral spine is going to give us information about the subcutaneous lipoma and the tract exactly where it is going in, which level it is at, whether it is at lumbar level or the sacral level, and we will be able to identify the facial defect as well as the bony defects. So, the bony defect, the facial defect is identified, and we will be able to identify the intraspinal component also along with the lipoma cord interface. So, we will be able to identify the fat from the extraspinal component to the intraspinal component, and we will be able to plan our surgery based on the type of the LMMCs, as we have seen in the classification systems enumerated by Pang and Chapman. So, urodynamic studies are also very important to keep a baseline prior to surgery, especially if the patient has urinary disturbances. It's wise to have a measure of these and the urinary function with urodynamic studies. Postvoidal residual urine is measured commonly, and anything more than 75 ml is considered abnormal, and we can counsel our patients accordingly. And if there is significant PVR, we may have to suggest the patient for clean intermittent catheterization and refer the patient to a physical medical rehabilitation expert or a urologist for management of the urinary disturbances. So, as I mentioned, the operative technique has certain goals. It is to detach the spinal cord from all tethering structures. So, this will be usually lipomas in the case of lipomyelomeningocele. So, this intraspinal lipoma with the lipoma cord interface has to be detached well. There may be sometimes presence of dermoids or dermoid cysts, as I mentioned in my previous slides. There is very common association of a fatty phylum terminal. So, that is why we asked for these thin T1 weighted axial cuts up to the coccyx to identify this fatty phylum terminal, which are commonly a secondary tethering element. So, once we have these fine cuts, we measure the thickness of the phylum, and in T1 it appears bright, hyper intense signal is seen, and anything more than 2 mm, that is a 3 mm sized fatty phylum terminal, is usually thickened phylum terminal, and if it is T1 hyperintense, it is a fatty phylum terminal. So, a 3 mm thick T1 hyperintense phylum terminal is called a fatty thickened phylum terminal. So, how to, and the second goal of operation is to decompress the intramedullary mass if there is any, and then finally to reconstruct the spinal cord and the dural sac. So, we saw that these patients have vertebral and facial defects. We should ensure that these facial defects and the sinus tract or the entire tract is removed, so that the patient has very less chance of developing infections. And all these three must be done safely using intraoperative neuromonitoring, as there is no point operating these patients and giving them devices, as the whole aim of the surgery was prophylactic. So, this is an intraop picture showing the sinus tract. The whole tract is being removed. Usually an elliptical incision is made in these children, and we see that this tract is entering through a facial defect here, and we can even identify the dural defect under microscopy. So, postoperatively these children are followed up with postoperative MR imaging. Although it is considered standard of care by some neurosurgeons, it is well understood that postoperative magnetic resonance imaging is not going to show much change in the conus position as compared to the pre-op MRI. It is not like a rubber band that goes up immediately once you cut the fatty phylum or the tethering elements. The conus is going to remain mostly at the same level, and usually this ascent of cord is best identified intraoperatively, where once the lipoma is removed and the fatty phylum is cut, we see a millimeter movement of this conus under microscope. So, it is not wise to do an POMR to see whether the cord has ascended or not. So, we can see residual lipoma after surgery and in the post-op imaging, and we can assess if there is any residual tethering. As I mentioned in the earlier slides, tethering is never a imaging finding. So, if there is residual lipoma and the patient remains asymptomatic, we are not going to offer resurgery. We would ideally wait for any deficits if the patient is developing, and then of a surgery ideally. So, the extent of resection can also be identified in the post-op imaging, and these three are the main things we look for in a post-operative MR. Some surgeons also like to follow up the syrinx if there was one in the preoperative imaging and see in the post-op imaging if the syrinx has vanished. Thank you.